Hello, Lotus. If everybody could take their seats, please, so that we can continue, that would be fantastic. Please do take your seats. Did you?
Yes. Thank you, Louise.
This is Dr. Ayman Shibana from Pakistan.
Ladies and gentlemen, if you could please take your seats.
You're welcome. I'm sitting.
Welcome back, everybody. If you could just please find your seats. Welcome back to the second session of this Religion and Medical Ethics Symposium. For this event, we are delighted to have the support of the BMJ, the British Medical Journal, as content partners. The BMJ have 140 years of experience as publishers of some of the world's most highly regarded medical journals. One of the BMJ's specialist publications is the Journal of Medical Ethics. And ahead of today's meeting, editors from the journal put together a background paper for this event that considers the medical ethics of deciding for others, particularly in the context of old age and mental health at the end of life. I'd now like to invite one of the authors of that paper, Professor Julian Hughes from Bristol University, to outline a medical approach to palliative care. Julian, thank you.
Hello. I'll start again. I want to thank Wish and the Pontifical Academy for putting on this wonderful and important event. I'll try and get through this as swiftly as possible. I think I have two things to do. One is to discuss the paper which has just been mentioned, which you have in your packs. And so the first 3 points on the screen really just doing that. I'm not going to go through that paper laboriously. I'll just highlight a few points. And then the final thing I have to do is consider, because this is in the title that I've been given, to consider the role of religion in medical ethics. And I think at that point, I'll definitely become incoherent. And that's partly because of my inadequacies, but it's also because I think it's a very difficult topic. We would have to define religion for a start, then we'd have to define medical ethics, and then we'd have to put them together. So I think it's a complicated issue. So the first thing I'm going to do, let me just check if this is the first thing I'm going to do. Yeah, well, no, it's not quite. So the first thing I'm going to do is just talk a little bit about the first case. So this is the case of Mr. Al-Hamad. And he's a man with Alzheimer's disease, and the case was designed to be a fairly sort of typical case of Alzheimer's disease. So he starts with fairly simple forgetfulness, but eventually this progresses. It starts to involve other cognitive mental functions. So, for instance, he's not able to do things, so he loses his praxis and so on. I think the key thing, maybe from the point of view of this meeting, is to remember that in advanced Alzheimer's disease, as in other types of dementia, of course, the disease affects the whole of the body. So we might start by thinking that dementias are in the head, that it's just the brain and you become a bit forgetful. But eventually, the brain, of course, is connected to the rest of the body, and changes occur in the rest of the body. So in the most advanced stages, and bearing in mind that, given that this is a palliative care, we're thinking about palliative care, bearing in mind that, of course, you can die from other things while you have dementia. So you may have dementia, but you may die from your heart failure or your cancer and so forth. But if you survive into the severer stages of dementia, then eventually you will be totally dependent, your gut won't work so well, you'll be incontinent and so forth, you'll not be able to move your limbs, you'll be bedbound, and so on. So poor Mr. Al-Hamad goes through those sorts of stages. So now, I'm not going to say any more about the story of Mr. Al-Hamad in detail now, but you can always read that later if you haven't already. But there's a general point to make, I think, which is how difficult this is for the family to witness. So the family see this man who's been very successful, he's been ebullient, he's been a patient father, he's been a kind husband to his wife, and so on. And he turns into this man who becomes rather irascible. Sometimes, in the end, he's agitated and even aggressive. So this leads to a general reflection, which is how do we understand this change in personality? Now, there are many people who will say that actually he's changed as a person, and there's a whole sort of literature about this, which many of you will know about, and so I won't go into it in detail, but some people argue that in the later stages, Mr. Al-Hamad is no longer the same person as he was before, and this raises issues about things like advance directives. So if he made an advance directive early on, would it be applicable later on when he's no longer the same person? Some medical ethicists have gone so far as to say that he's not a person at all, that you lose your personhood in the context of severe dementia. So the question is, how do we understand these changes in personality? I mean, there are complex issues here because we can talk about the person, we can talk about personal identity, which it might be a slightly different topic, and we can also talk about personality. So we might want to say that it's the same person, different personality, but you'd have to think a bit about what you mean by that. And of course, a religious perspective will give you a particular sort of view on what's going on here. But of course, what's going on here may also be a challenge to your religious perspective. So it's worth bearing those points in mind. I just want to note something. We should note about Mr. Al-Hamad that he does have religious beliefs. We know something of this because we know how he accepted the death of his own parents. But he may have other beliefs which the family might know about. He may have beliefs about the role, and we've heard a bit about this already this morning, about the role of suffering and death in our lives. So those are things to keep in mind. And a second little note to flag up is that he has, when he goes into hospital, he has a do not attempt resuscitation order made, but we need to note that then the issue that comes up later is whether he should have PEG feeding, so artificial feeding, and we need to be clear that these two decisions are distinct. So one is about resuscitation in terms of cardiopulmonary resuscitation, and the other is about feeding him. And these are different decisions, albeit we might want to think that because he's got one, he's more likely to want to have the other sort of advanced statement. Now, I want to make three quick empirical points about this. So the first is that hospital doesn't work. Of course, this is a generalization. Hospital will sometimes be good for some people. But in this case, as in so many, Mr. Al-Hamad goes into hospital and it just makes things 10 times worse. He becomes agitated and aggressive and so forth. Hospitals are very upsetting environments for people with dementia. And also the question is, do they do any good? And I've put here on the screen a really good, I mean, it's a slightly old paper now, but it's a good paper of showing what happens to people with dementia when they go into hospital. So Liz Sampson from UCL in London did this study, and I don't have time to go into the details of the study, but essentially she showed that as your dementia gets worse, you're more likely to die if you go into hospital. But the reason I put it up is because I want to read you something from the discussion of that paper, where Liz and her co-author say, "We cannot judge from our data whether these admissions were necessary, but the high short-term mortality risk in people with dementia suggests that this intervention did not prolong life for a meaningful length of time. Individuals may have received better quality care in a familiar environment if more support were available in the community." So that's just a fact I want to sort of flag up. The second thing I want to say is that resuscitation doesn't work. So there are not many studies of this, and I have looked several times since I first looked this up and can't find any better studies. There are some other studies about resuscitation in people with dementia, but this study looks at the chances of survival if you have cardiopulmonary resuscitation in hospital, and the chances aren't good, but the chances of survival in dementia are about the same as they are if you have metastatic cancer. So if your cancer has spread throughout your body, we would normally not be thinking about resuscitating you. So why would we do the same thing if you have advanced dementia? And then the third empirical point is that PEG feeding doesn't work. So again, you can see I'm a bit of a fan of Liz Sampson. I think she is one of the best researchers in the UK on palliative care and dementia. And she did a systematic review about tube feeding. So in the case we're talking about PEG feeding, so this is where a tube is put straight through the abdominal wall into the stomach. And people think that this will solve problems because they think that the person will put on weight, that it will protect the skin, they won't get pneumonias caused by aspiration and so on. But it turns out that none of those things is true, that actually people still get aspiration pneumonias because you've still got mucky stuff going down and you've still got stuff regurgitating upwards and going into your lungs. And even if you're being fed the right number of calories, you still lose weight and you still have problems with your skin. So these are all things we ought to keep in mind. And all of that leads me to talk about what we've already heard actually about this morning, which is the doctrine which is usually called a Catholic doctrine of ordinary and extraordinary means. So I'm going to put up a slide in a minute or two which will lay this out. But just to say, so what is this doctrine? It's the doctrine that we're only morally obliged to do the ordinary things. We're not morally obliged to do the extraordinary things, although, of course, we might choose to, but we're not morally obliged to. So then the question is, well, what makes something ordinary or extraordinary? And the answer that's given is that it's extraordinary if it's unlikely to be effective and if it's burdensome both to the person but also to others. So there we go. Now, the talk is about medical ethics, religion, and the sort of relationship between the two. So, it's generally said that that's a Catholic doctrine. And here we have a well-known Catholic, Pope John Paul II, of course, who's now a saint. And here we have him saying, Euthanasia must be distinguished from the decision to forego so-called aggressive medical treatment. In other words, medical procedures which no longer correspond to the real situation of the patient, either because they are by now disproportionate to any expected results or because they impose an excessive burden on the patient and his family. Certainly there is a moral obligation to care for oneself and to allow oneself to be cared for, but this duty must take account of concrete circumstances. So I think that's a good quote from Pope John Paul II. So there we see it in Catholic tradition, but also in the UK, or rather in England and Wales, we find it in our Mental Capacity Act. So if you look in the Code of Practice there, it says all reasonable steps which are in the person's best interest should be taken to prolong their life. There will be a limited number of cases where treatment is futile, overly burdensome to the patient, or where there is no prospect of recovery. In circumstances such as these, it may be that an assessment of best interest leads to the conclusion that it would be in the best interest of the patient to withdraw or withhold life-sustaining treatment, even if this may result in the person's death. So it's interesting that in this, so here we now have a secular thing, a law from England and Wales, using just the same words as the Pope used, more or less. It's futile or burdensome, and then you don't have to do it. The only thing I would disagree with in this statement is the statement, there will be a limited number of cases. I think it's actually quite a few cases where this is the case. And then the third thing I want to say about this is, so we've had the Catholic tradition, we've had the use in secular law, and also I think it's very useful in clinical practice, and certainly over the years, numerous times I've used exactly these words to explain to families or to discuss with families why we may not be admitting their loved one to the hospital, why we may not be ordering cardiopulmonary resuscitation, and why we may not be wanting to artificially feed them. Okay. So now on to the second case, which is the case of Miss Jones. Miss Jones is someone we don't know very much about. We know that she's a Catholic, but we don't know anything much about her beliefs in any more detail. We simply don't know very much about her. But what's clear is that she does have a fairly marked depression. And it's become so bad that the only treatment that looks like it might work, lest she die, is electroconvulsive therapy. We need to go for that sort of treatment because she's no longer eating and drinking. She's just fading away. She turns away. She doesn't talk to anybody. At one stage, she has said, "Well, just let me die," but then she's not speaking at all now. So she does have a severe depression. And then I've put up here these details about this doctrine of ordinary and extraordinary means. And the question I want to ask now is, let me interrupt myself to say, so in the first case, I think the doctrine of ordinary and extraordinary means can be easily applied, and I don't think we should be treating Mr. Al-Hamad over vigorously. I think we should be allowing him to die peacefully. In this case of depression, which of course fits in to some extent with what will be discussed tomorrow, I'm not sure what to do. So when I think back to my time as a clinician, I know that I've seen people like this where we've decided to go ahead and give them ECT and get them better and so forth. But I also know that there have been times when we haven't. We've just accepted, as it were, that the person had had enough and that this was going to be the end of their life. So you can ask those questions, will it be effective? Well, ECT, the evidence is that it's probably the most effective sort of treatment in this sort of situation. But all it does is speeds up the recovery. It doesn't absolutely guarantee the recovery. If it does guarantee the recovery in the short term, will it maintain the recovery, and so on? Of course, it is going to be burdensome in some ways, but there are ways of mitigating that. So it's very difficult to know exactly what we should do in this case. There's a question about whether religion has a role here. So we do know something about her religious beliefs, but we don't really know enough to use religion in order to make the case for or against it. Here I want to say that, of course, there can be what I might be tempted to call mistaken religious beliefs, or at least what we might be seeing is just differences in terms of religious beliefs. So you might have somebody coming in and say, well, she should be kept alive. That's what the Catholic Church would want. But the answer is, well, the Catholic Church might prefer us to think harder about the doctrine of ordinary and extraordinary means, and that might tempt us to say, no, she really has had enough, and it's going to be a big struggle to get her back, and we should now just be palliating and keeping her calm. So I think it's very difficult to know. So you might say, well, how do you decide? I mean, so in these cases where you've kind of walked away or given her ECT or whatever, what was it that decided? And I can't honestly tell you, but the closest I can get is to say that maybe sometimes it's the look in the person's eye. So you're trying to talk to them, they're not responding to you, they're turning away, and you make some sort of a judgment by the look in their eye. This reminds me of the great Jewish philosopher, Levinas, who spent a lot of time talking about the face and the importance of the face. And I wonder if it's something like that. Well, I'm going to push on. So what we did in the paper is that we then just highlighted some particular issues. I'm just going to think about some of those. Actually, I'm not going to think about those ones yet. So one of the issues that we raised is the issue of autonomy. For the sake of time, I'm not going to say very much about that, except to say that we then talked about relational autonomy. So this is recognizing that although people might want to make autonomous decisions, these decisions are made in the context of relationships with interdependency and interconnectivity. So there's that issue. There's second issues that we raise are to do with capacity and best interests. And the only point I want to make about these issues is that they sometimes look as though they may be tick boxes, that you can tick the boxes to say whether the person has capacity or lacks capacity. Then you can go on and tick boxes to show that you've thought about best interests. In fact, in the code of practice that governs England and Wales, there's a best interest checklist, so you're almost encouraged to go and put your checks by it. But what I want to say is that actually these are difficult notions, that they are evaluative notions, they're not just factual things. There's now something, as well as evidence-based medicine, we also have values-based medicine or values-based practice, which encourages the view that values are, or highlights the point that values are everywhere, and that where there's shared values, things go along smoothly, but where there's values diversity, things don't always go quite so smoothly. And then I just want to look very briefly at these different ways of making decisions. And again, I'm not going to say much about them. Many of you will know all about them. But so we have proxy decision making where somebody else makes the decision for you. And then there's this substitute decision making, which is what many people use in many countries, where you're meant to sort of put yourself into the shoes of the person and decide what they would have wanted under these circumstances. But there was this I was about to say Pope, but it's actually Hope. There's a good paper by Tony Hope and colleagues talking about this and saying that actually something rather magical has to happen in order to do this. First of all, I've got to put myself into your shoes, but then I have to put myself into your shoes when you're in this terrible position and know what you would think then, and then make a judgment about that. So it's not as straightforward as we might think. Then, of course, becoming more popular is the idea of shared decision-making, but that's problematic, isn't it? What's real shared decision-making? Is it really shared decision-making, or is it the doctor suggesting all sorts of things, so in the end you say, oh yes, that sounds like a good idea? The people who love shared decision-making would say, no, that's not the case, you have to do it properly, and then it will be genuinely shared. And finally, there's this notion which has been pushed by the UN Convention on the Rights of Persons with Disabilities, which would include people with dementia, of supported decision-making. So this is the idea that you don't take away the decision-making from the person, you just support them to do it. But it's problematic, and it's problematic for a couple of reasons, but I think summed up maybe in this statement, which again was from the Journal of Medical Ethics. Not that I'm biased in any way towards that journal, but it just so happens that many of the references come from that journal today, which means I am biased. So that was a joke in case you thought I was telling a lie. So what this says is that notwithstanding its promise, supported decision-making has its limits. Undeniably, there are situations where despite the decision support offered, a patient remains unable to make an informed treatment decision. The comatose patient provides a pertinent example, but similar considerations hold for a range of persons with other conditions, such as late-stage dementia or psychosis. So you might think of Miss Jones as having a sort of depressive psychosis. Accordingly, supported decision-making does not make competence assessment and substitute decision-making superfluous. That said, reasonable accommodation requires health professionals to exhaust the available resources of supported decision-making before they take recourse to substitute decision-making. So I'm going to end that section there. I think that, so the first section I ended talking about the face and looking into people's eyes. I think this section is all to do with relationships, our relationships which enable us to make good judgments about what's in somebody's best interests and whether or not they have capacity and so forth. And underpinning those things, we want to say in the paper which has been distributed, is something to do with the notion of the person and the nature of personhood. So now I'm going to move on to talk about what we've called the C view of the person. So the C view stands for the situated embodied agent view. And again, I'm not going to say much about these things in detail. But of course, the importance of embodiment is pretty obvious. And that means in several ways. One thing is that sometimes you can tell what somebody is thinking through their body, of course, by their gestures and so on. But also it's important to know what's happening physically, to know what's happening in terms of their biochemistry, say. I'm not going to say much about agency either, because I think the crucial thing here is the notion of being situated. I think that the agency at the terminal end of a dementia is situated agency. So in other words, other people might be able to hold that agency for you, even though maybe you can't demonstrate your agency yourself, although you might do in certain sorts of ways. There may still be gestures even in fairly advanced dementia. So just to think a little bit about this notion of agency, of being situated. So we're situated in all sorts of different fields. There's our whole sort of culture to do with our traditions, norms, and histories. There's our personal history. There's a social context. There's the whole kind of field of morals, which might include a variety of things, including our values and the sense of virtues. And then also there are spiritual values, and there's formal religion. There's some sort of more nebulous openness to some sense of the other. Now, the reason for formulating this characterization of the person was it was aimed against what I call the Locke-Parfit view. So John Locke and Derek Parfit had views about what it was in terms of personal identity, which emphasized memories or psychological continuity and connectedness. And of course, that was the threat to people with dementia, or to the personhood of people with dementia, because people with dementia lose that psychological continuity and connectedness. And so I wanted to encourage this sort of broader view. So I think what this view does, this situated embodied agent view, is that it shows to some extent how the person can be held by others, but you might want to ask how far we can push that. It shows that personhood can't be circumscribed. It can't be pinned down, because there's always some other way in which I might want to express my personhood. It shows that what's relevant in making decisions is very broad. The person's also seen as part of a context and also as embedded in relationships. So we start to see the person as a bigger whole. And there is a chapter I've written somewhere, which I think might come up at some point on the slides, where I've dared to say that the person is also situated as an example of something rather than nothing. So actually this notion of being a situated person might be taken to raise what somebody like Herbert McCabe would have called, the Dominican Herbert McCabe would have called the God question, which is why something rather than nothing. So I think in the cases we've been discussing, I think that this broader view it encourages this bigger perspective. So it encourages the bio-psychosocial and spiritual view. For Mr. Al-Hamad, it stresses the importance of the family, for instance. It also stresses the importance of the body, So we can think about embodied understanding, and we can think about tacit knowledge, and those things seem to me to be relevant in the case of Miss Jones. Well, I then want to just come on now, I think. I was going to just highlight this, which is the Nuffield Council on bioethics some years ago produced a report on dementia, and I just wanted to highlight that two of the things they emphasise in that report as part of the kind of core values were the notions of solidarity and personhood. So now I want to come on to this, on to what we can say more specifically about religion and medical ethics, and I'm inevitably going to rush through this, but I'm going to give myself enough time just to mention Wittgenstein, because I love the philosopher Ludwig Wittgenstein, and he once said that he would quite like to use as a motto a line in one of his books, a line from King Lear, which is where Kent in Act 1, Scene 4 says, "I'll teach you differences." And I think that that's mainly what we've got to think about, that there's a variety of ways, that there's a variety of meanings of religion and medical ethics and so on. So there's going to be a variety of roles for religion in terms of medical ethics. So one thing is just to think about the culture of religion. And what we can say is that medical ethics draws from that. So we only have to think about the virtues, things like compassion, honesty, fidelity, integrity, and so on. And we see that these are directly drawn from religion. Nowadays, they're often associated with the Catholic religion, but actually, they come from Aristotle, and they came to the Catholic tradition via Islamic intellectuals and also through Jewish intellectuals as well, and then made their way to Aquinas, who then used them very effectively. So there's that sort of thing. There's a slightly sort of mundane thing of just religious traditions and decision-making and so on, that religious traditions are helpful in terms of decision-making when we're deciding what to do with somebody at the end of life. It may be that a religious advisor will come in and help us to see that the right thing to do under this circumstance is such and such. I also think we heard the word this morning from one of our other speakers, and I'm sorry I've forgotten exactly who it was, but we heard the word inspiration. And I think that religions can inspire people. Now, of course, you can be inspired without religions, but I think there's no doubt that religions sometimes themselves inspire people. They might inspire people to be overzealous in one way or another. So they might inspire people to try to keep people alive at all costs, and we've already heard that the various faith traditions will have arguments against that possibility. They also inspire the public sometimes to be overzealous. So I think of some of the fairly vicious attacks that occurred on staff in the London hospital looking after the little baby called Charlie Gard. Vicious attacks, I mean verbal attacks. Staff being rung up in the middle of the night and just accused of being murderers and so forth. Well, there are other things to think about, that religious beliefs and teaching can support certain sorts of approach. So we've heard about ordinary and extraordinary means, for instance, in this paper by one of my colleagues, Kenneth Boyd, who's here. Kenneth cites some of there's a series of papers in the Journal of Medical Ethics, and Kenneth is sort of summing them up, and he quotes some of them saying that moral theologians' modus operandi is not so very different from that of any decent moral philosopher. So I think that there are those sort of connections. Religion, it also supports a certain sort of understanding, and so we've already heard about the notion of solidarity, which again has some sort of religious roots to it. And religions can support a certain sort of perspective. And so I'm putting forward this C view, so it's a broader perspective, and one in which the person is seen, as it were, in communion with others, where both personhood and solidarity acquire importance. There's obviously a lot more to say about the connections between religion and medical ethics. I think it's safe to say that whether contentedly or discontentedly, they're likely to remain bedfellows for some time to come. And with that thought, thank you very much for your attention.
Thank you, Professor Hughes. Yes, please do take a seat because I'd like to ask Dr. Galli and Professor Centeno to join us up here on stage as we'd like to take some questions from the audience. Unfortunately, Dr. Di Segni has had to leave us, so he won't be able to join us, but I'm sure we can get a good discussion and answer many of your questions here with our three guests. So we've also had some questions submitted on the Slido app. But before we turn to those, a very quick question that I have myself, Professor Hughes. And that is about the difference between Alzheimer's and dementia, because I was led to understand that there was a difference, and yet I see in your case study with Mr. Al-Hamad, you use them interchangeably. Yes, that one there. Yeah.
Thank you for the question, because it's useful to clarify that. So dementia, again, I'm sorry for those of you who already know all of this, but dementia is an umbrella term. So it doesn't actually define a particular disease. So if you think of dementia as covering all sorts of different types of disease, and then under the umbrella we have the various types of dementia. It's said that there are probably over 100 different types of dementia, but the big ones are Alzheimer's. Alzheimer's is about 50 to 60% of cases, then vascular dementia, then Lewy body dementia, and frontotemporal dementia. So each of those particular types of dementia has its own particular types of symptom. But there are lots of other types of dementia as well. So it means that if you say somebody's got Alzheimer's, you're allowed to say that they've got dementia. But if you say someone has dementia, they may not have Alzheimer's, they may have vascular, they may have Lewy body dementia, they may have a sort of dementia caused by brain trauma.
Thank you very much for clearing that up. Very interesting to know. I think that is still something many members of the public misunderstand. So thank you once again for joining us, and hopefully we have lots of questions from the floor, so maybe we can turn to Slido when we've exhausted, if we exhaust questions from the floor. And we have some roving microphones. If you could stand up, tell us your name and where you're from, please, and who your question is directed to, if anyone in particular.
Thank you very much. My name is Hussein from University of Warwick. I am sociologist in terms of training, and I'm sociologist of religion. I must say that I enjoyed all the sessions today. Today morning, I can see from the perspective of religious pluralism, there are lots of commonalities between three religious traditions, the way I saw, between Islam, Judaism, and Christianity. But my point, one thing is, of course, I want Professor Hughes, if he can shed some light on this point, is that as a sociologist, I was thinking, all these 4 sessions tackle the issue of medical ethics more or less from objective perspectives. And I was thinking some sort of subjective approach, probably from social scientific perspective, would be very useful. And I am thinking, the world is changing dramatically under global forces and globalization, etc. It's becoming terribly diverse. And this diversity, of course, contributes to this issue of subjectivism. I was thinking how this subjectivism is reflected in medical ethics. For example, in terms of religious diversity. Yeah, we are thinking about Islam, but Islam is not a generic term from social science perspective. Each individual understands Islam, a Muslim, in different way. and how these things, this diversity, is reflected in your practitioner, in medical practices. Is there any way? Let me ask the question this way. We understood that there is a role for religion. Should there be any role for religion in medical practices in terms of subjectivism or not? I hope I am a bit clear.
Lots to think about there.
Well, thanks for the question. I should say that we've just had a little chat before this,
Sure.
and I revealed that I did my PhD at Warwick. So this now feels like I'm back in my PhD viva. This time I may not get through. So I think you're right. I think that the issue of subjectivism is important. And I think that's a very useful, I think one of the things you've said is just very useful, which is to recognize, and people will have to excuse the pun, that religious faiths are very broad churches that both in, we know in Judaism, in Islam, in Catholicism, you can have right wings and left wings, you can have, all sorts of different beliefs even within the one faith. But I'm going to simplify your question, and I hope this means that I still address it. I'm just going to think about, so what would one actually do, as it were, in practice? And I think that in practice, the thing I skirted over a bit was this notion of values-based practice. And one of the things that says, and it sounds very simple, but of course it's really important, is that you need to get all the values out into the open, that you need to get them all on the table. So you have to get people around and get them to say what they actually believe and think and to kind of reveal their values. And then the rather complex thing is you have to kind of figure out a way to sort of deal with that. The chap who was really my mentor and was at Warwick was Professor Bill Fulford. And so he's been pushing this values-based practice. And he ends up, so he has kind of 10 key elements. And the final element is to do with partnership, but where he says that you should aim for consensus, but he says you may have to put up with dissensus. In other words, that some people will just have different views that you may not be able to accommodate. But what you should at least do is take them seriously and show that they're still being recognized just in case something else changes. That's probably not a completely adequate